So what we will do now is look at the development of the GI tract and organs related to the GI tract, primarily through a series of cross-sections through the embryonic abdomen. Now, those cross-sections are represented in the notes by a series of diagrams that you can see here. We have a series that refer to the development of the liver, and then development of the pancreas, and then the spleen, and then the secondary retroperitonealization and the rotation of the gut. But in order for us to have a more robust conversation about these, we'll use a larger representation of each of these diagrams. So starting with the first one, this will represent a cross-section through an embryonic abdomen. It clearly does not represent all of the contents of the embryonic abdomen. It's only those elements that are relevant for the conversation that we're having here. So things such as the vertebral column and the spinal cord and so forth are not shown here. On all of these embryonic cross-sections, dorsal will be at the top of the figure and ventral at the bottom. The right will be on the figure's left and the left will be on the figure's right. Now, since this represents a cross-section through an embryo, we would anticipate that the outer surface of that cross-section would be ectoderm, and so it is. The inner layer of the cross-section would be endoderm, and we expect that between the ectoderm on the outside and the endoderm on the inside, we should have mesoderm, and we already know that mesoderm in most of the embryo will divide into two layers with a cavity in between. So here are the two layers of mesoderm, and the cavity in between we previously said will be called the coelom. So there's the coelom. Now, because we're going to want to go back and forth between the embryonic anatomy and the adult anatomy, and because the nomenclature, the names assigned to structures are different for the embryo and the adult, this could cause confusion as we change names as we go back from embryo to adult and back. So for the most part, even when we're looking at the embryo, we'll try to use the adult nomenclature to avoid confusion. So instead of calling this the coelom, we'll call it the peritoneal cavity, which is, of course, what this becomes. And therefore, the two layers of mesoderm we will call the two layers of peritoneum. This outer layer that is ectoderm, we'll refer to that as the body wall. That's not precisely ectoderm. That's a little bit more than ectoderm, but that's good enough for our conversation. And then this innermost layer, which is lined by endoderm, of course, is the gut tube. Now, we know that there are never any organs that are found in the coelom, regardless of whether that's the coelom that becomes peritoneal cavity or pleural cavity or pericardial cavity. There are never any organs that are within that derivative of the coelomic cavity. So that means that on this diagram, there are only two places where organs can develop. They can either develop in here, surrounded by the peritoneal cavity, such as the gut tube, or they can develop out here, outside of the peritoneal cavity, and represented here are two examples of such organs that would represent the kidneys, and that would represent the aorta. So we can have organs out here, or we can have organs in here, but there are never any organs in here or here. And it's based upon that distribution of where organs can be found that there has developed a system of nomenclature that is very important for us to understand, because virtually everything we're going to talk about in the abdomen is going to be based upon this. So let's review the rules of nomenclature for the abdominal viscera. When you have an organ, such as this organ, an organ that is completely surrounded by peritoneum, and before we go any further, let me just point out to you that on all of these diagrams, the spaces that are seen between these lines don't really exist. Those lines are really touching one another, but in order to illustrate that they really are two lines, we've shown them with a space in between, because if they touched, they would look like one line. But recognize that all the space that you see in here doesn't really exist. So when you have an organ such as this that is completely surrounded by peritoneum, we call that kind of an organ a peritoneal organ. On the other hand, when you have an organ such as this that is covered by peritoneum but not completely surrounded, we call that kind of an organ a retroperitoneal organ. So to review that, we're saying peritoneal organs are organs that are completely surrounded by peritoneum, and retroperitoneal organs are organs that are covered by but not surrounded by peritoneum. So that's the first rule. The second rule is that the peritoneum that surrounds a peritoneal organ, in other words, this peritoneum that's surrounding a peritoneal organ, will always be called visceral peritoneum. And the peritoneum that covers retroperitoneal organs will always be called parietal peritoneum. So the second rule is visceral peritoneum is the peritoneum surrounding peritoneal organs, and parietal peritoneum is the peritoneum covering retroperitoneal organs. Thirdly, the peritoneum that connects parietal peritoneum to visceral peritoneum. This is parietal, this is visceral. So here's peritoneum that's connecting parietal to visceral peritoneum. That will always be called mesentery. Mesentery. Now on this cross-section, you can see that we have two mesenteries. We have one here, and we have one here. And we name those two mesenteries according to which side of the gut tube they are on. So we said this is the dorsal side, so this is on the dorsal side of the gut tube. So we'll call this mesentery the dorsal mesentery, and we'll call this mesentery the ventral mesentery. Now it's important for us to understand that mesenteries serve a purpose. There's a reason that we have mesenteries. And that purpose can best be illustrated in this fashion. We know that the gut tube requires a blood supply. And we also know that the source of that blood supply is going to be from the aorta. So the problem that we have is that the aorta is a retroperitoneal organ, but the gut tube is a peritoneal organ. So we have to get a branch, an artery, from that retroperitoneal position to that peritoneal position, but we're not allowed to pass that artery through the peritoneal cavity to get from a retroperitoneal to a peritoneal position, because we can't have anything in the peritoneal cavity. So how can we get an artery from the aorta back here to the gut tube here? And the answer is by running that branch within the mesentery, within the mesentery. So by staying within the mesentery, we're able to get from a retroperitoneal position to a peritoneal position without ever being in the peritoneal cavity. And indeed, when you look into an abdomen, and if you lift out a loop of intestine and look at the mesentery supporting that loop of intestine, what you'll see passing within the mesentery, if you look through the mesentery, you'll see arteries and veins and nerves and lymphatics inside of the mesentery, and they are all doing what we see schematically represented here, passing from retroperitoneal to peritoneal positions. So that's what mesenteries serve as. They serve as bridges or conduits to get structures from retroperitoneal to peritoneal positions, and therefore we can infer that all organs that are peritoneal organs will receive their blood supply through mesenteries, and that's going to be true. Okay, so what we need to do now is start a process of modifying this basic picture, and with each modification we will develop an organ. So the first modification that we're going to have will involve a ventral midline evagination of the endoderm of the gut tube. So from the midline of the gut tube on the ventral side, we see this evagination that grows out of the gut tube, growing ventrally. Now, since we can't grow into the peritoneal cavity, the only place we could grow into the so-called space between the two layers of the ventral mesentery. So it grows into the ventral mesentery, and that endodermal evagination is called the hepatic diverticulum. So that name tells us that what will develop from this will be organs relating to the liver. Okay, so that's the hepatic diverticulum. So the first thing we can see is that the hepatic diverticulum is in fact an endodermal evagination. So that would suggest to us that liver-related parenchymal cells will be endodermal cells, and indeed they will be. Now, the distal end, or the most ventral end of this hepatic diverticulum, is going to expand in order to develop into some organs. And looking at this, we can recognize that if the distal end of this diverticulum is going to expand, that means the two layers of the ventral mesentery between which it is living, those two layers of ventral mesentery will have to spread apart to make room for that expanding diverticulum. And that's what we'll see on the next slide. We see that indeed the ventral end of that diverticulum has expanded, and we see that the ventral mesentery has spread apart to accommodate it. This distal expanded end of the hepatic diverticulum is what will develop into the liver and gallbladder. The more proximal part of that diverticulum, the part that hasn't expanded, is what will develop into the bile duct, or more generically, the biliary duct system. So the common bile duct, the hepatic duct, the cystic duct will develop from the hepatic diverticulum as well. So now we can say that not only do the hepatocytes develop from endoderm, but we can say that the epithelium of the gallbladder, the epithelium of the common bile duct, the epithelium of the entire biliary duct system is also developed from endoderm. Now, when we look at this organ, this liver that we've developed here, and again remembering that the spaces between these lines don't really exist, if we ask ourselves the question, is that organ completely surrounded by peritoneum? The answer is yes, it is. And because it's completely surrounded by peritoneum, we therefore have to call it a peritoneal organ. And because we're calling it a peritoneal organ, that means that the peritoneum that's surrounding it has to be called visceral peritoneum. So this peritoneum is now going to be called the visceral peritoneum of the liver, even though just a few moments ago we were calling that very same line the ventral mesentery. We said that the hepatic diverticulum grew into the ventral mesentery. We said the ventral mesentery spread apart to make room for it. And now we're saying that part of the ventral mesentery that spread apart to make room for it is now being called the visceral peritoneum. Not because that peritoneum has changed, it's the same peritoneum, but because it's now surrounding a peritoneal organ, and since we have rules that we follow about nomenclature, we now have to change the name and call this visceral peritoneum of the liver. So while it is correct to say that the hepatocytes of the liver are derived from endoderm, the visceral peritoneum of the liver is derived from ventral mesentery. Well, now that we have renamed this part of the ventral mesentery, we've renamed it visceral peritoneum, that leaves us two other parts of the ventral mesentery, here, and in the adult, each of those will be given a new name. The part of the ventral mesentery between the liver and the ventral body wall, or between the liver and the parietal peritoneum of the ventral body wall, that's going to be called the falciform ligament. And that part of the ventral mesentery between the gut tube and the liver, that's going to be called the lesser omentum. So now we're saying that not only is visceral peritoneum derived from ventral mesentery, but also falciform ligament and lesser omentum are derived from ventral mesentery. And indeed, those three adult structures, lesser omentum, visceral peritoneum of the liver, and falciform ligament, are the only three adult structures that are derived from ventral mesentery. All of the remainder of the ventral mesentery, of the entire remaining length of the gut tube, will disappear. So there won't be any adult derivatives from it. The only part that is retained is what becomes the falciform ligament, visceral peritoneum of the liver, and the lesser omentum. Now, an important adult anatomical point that we can infer from this, we see that the bile duct is now in the part of the ventral mesentery that we're calling the lesser omentum. And so we should anticipate that in the adult, the bile duct will be found inside of the lesser omentum, and indeed it will be. So we can see now the embryonic basis for the adult anatomy that tells us that the bile duct must be found within the lesser omentum, and that's indeed where it is. Now, although we started this conversation by saying that there was a ventral midline of the gut tube, and we call that ventral midline diverticulum, rather, of the gut tube, and we call that diverticulum the hepatic diverticulum, we didn't say which part of the gut tube has this diverticulum emerging from it. Where along the gut tube are we when we find this hepatic diverticulum? And we know that the part of the gut tube that has that happen is the part that we will end up calling the second part of the duodenum. So we've now developed the liver and the biliary duct system and the falciform ligament and the lesser omentum. And so now, before we move on, let's take a look at how this all relates to the adult anatomy. So if we look at the adult anatomy of this region, what we should anticipate is that between the liver and the gut tube, we should find the lesser omentum. Between the liver and the ventral body wall, we should find the falciform ligament. And within the lesser omentum is where we should expect to find the bile duct. So let's take a look at the adult anatomy. So here's the gut tube, represented by stomach and the beginning of the duodenum. There's the liver, and sure enough, between the liver and the gut tube is where we find the lesser omentum. And then between the liver and the ventral body wall, remember the ventral body wall, of course, has been removed, so we've cut off the falciform ligament at this point, but here we see the falciform ligament going from the liver to where the ventral body wall was. So there is falciform ligament, visceral peritoneum of the liver, lesser omentum leading us back to the gut tube. And if we could dissect open this lesser omentum right in there, inside of the lesser omentum, right along there, that's where we would find the bile duct going from the liver to the duodenum. Okay, so that's where we anticipated it would be found, and sure enough, that's where it is found. Okay, so now let's move on and see how we can develop another organ. So coming back to our cross-section, we've now modified it in a somewhat different way. Now this cross-section is just at about the same place that the first one was, so this is still the second part of the duodenum. This time we see that the endoderm of the duodenum evaginates, but we have two evaginations. We have a ventral evagination and a dorsal evagination from the ventral midline and the dorsal midline. The ventral one evaginates into the ventral mesentery, the dorsal one evaginates into the dorsal mesentery. Those evaginations are called the pancreatic buds. So this would be the ventral pancreatic bud or ventral pancreatic diverticulum, and the other is the dorsal pancreatic bud or dorsal pancreatic diverticulum. Now, if we stop the discussion at this point, we would anticipate that we are going to end up with two pancreases. But of course, we know we don't end up with two pancreases. We only have one pancreas. So something must change. And what changes relates to this ventral pancreas, ventral pancreatic bud, and the fact that it's now in the ventral mesentery. You recall that just a few moments ago we said that almost the entire ventral mesentery is going to disappear. And indeed, this ventral mesentery in which the ventral pancreatic bud is now living is going to disappear. So if that's indeed going to happen, that means that the ventral pancreatic bud can't stay there, right? It has to move. And so indeed, that's what happens. The ventral pancreatic bud migrates out of the ventral mesentery, and it will migrate around the gut tube, around the second part of the duodenum, to get from the ventral side to the dorsal side. It's migrating in this plane between the visceral peritoneum and the wall of the gut tube, and it will migrate around what in the embryo is the right side of the duodenum, and it will end up on the dorsal side of the gut tube. So we will go from this picture to this picture, where the dorsal pancreas is still in the dorsal mesentery where it's always been. The ventral pancreas, which used to be in the ventral mesentery, has now migrated around, gotten to the dorsal side, migrates into the dorsal mesentery where it's now living side by side with the dorsal pancreas. We're showing the ventral mesentery with a dotted line here to suggest that it is going to disappear a little bit later in development. So right now it's vacant, and so it's okay if it will disappear in a little while. So now we have both pancreatic buds living side by side in the dorsal mesentery, and indeed they will fuse together. And because they fuse together, that means we will end up with one pancreas. But even though we now have one pancreas, we see that that pancreas is still connected to the gut tube in two places, from the original dorsal diverticulum and from the original ventral diverticulum. So that would suggest to us that in the adult we're going to have one pancreas, but we're going to have two pancreatic ducts, and that both pancreatic ducts should be entering the second part of the duodenum. So let's see what this is going to look like. Here from the notes we have the image of a gut tube. There's the stomach, here's the duodenum. So this right here is the second part of the duodenum. This is what we've already talked about. That's the hepatic diverticulum. There's the gallbladder. The liver would be developing up here. And then we had these two pancreatic diverticula, a ventral one and a dorsal one. And then what we said is that the ventral pancreatic bud is going to rotate around the right side, which on this picture would be behind the screen, would rotate around the right side of the gut tube to get to the dorsal side, where it will then fuse with the dorsal pancreas. And so this ventral pancreatic bud that we see here on the ventral side is now over here on the dorsal side, and those two buds will fuse together. So we should anticipate that the pancreas will look like it has this little hook-like appendage on it on its bottom side. So that's what we should anticipate. And we also see that we had one duct here and one duct here, and now we'll have still two ducts, both ducts entering the second part of the duodenum. So let's see what the adult looks like. Here we have the pancreas. Here's the duodenum. This is the second part. The first part's been removed. Second part, third part. And we see that the pancreas indeed has this appearance of, looks like part of something has been sort of stuck onto the bottom of it, this little hook-like appendage to the pancreas. And so since we know that this adult pancreas is derived from two pancreatic buds, we should be able to infer where that line of fusion was between the two pancreatic buds, and that line of fusion would be approximately here, with one side of that line being the ventral pancreas, the other side of that line being the dorsal pancreas. And so this is ventral pancreas, that's what rotated around from the other side, and this was the dorsal pancreas, which was sitting in the dorsal mesentery all along. So we can say that in the adult, the lower part of the head and this little hook-like thing called the uncinate process is derived from the ventral pancreas, and the upper part of the head, the neck, the body, and the tail of the pancreas are all derived from the dorsal pancreas. We should also anticipate that the two pancreatic ducts, which we know will both enter the second part of the duodenum, since we know that one duct is derived from the ventral pancreas and one duct is derived from the dorsal pancreas, we should expect that the point of exit from the pancreas for one duct would be here and for one duct would be there. And indeed, we have a duct that comes out of the pancreas and goes into the second part of the duodenum here, and that's the one that's called the major pancreatic duct. Sometimes you'll hear it referred to as the duct of Wirsung. And then the duct derived from the dorsal pancreas is going to be here, and that's the smaller of the two, called the minor or accessory pancreatic duct. Sometimes you'll hear it called the duct of Santorini. And that also enters the second part of the duodenum, but will enter it a little bit more proximally than the major duct, and that's always the case. And then we should anticipate that because the two pancreatic buds fuse together, that those two duct systems would fuse together, and indeed that's what happens. So within the pancreas, within the body and tail of the pancreas, we have a single duct, and then as we approach the head, it bifurcates into two ducts to enter the pancreas separately. And that's representation of the original two separate pancreatic buds, each providing a separate duct. So that's the normal appearance of the pancreas, and we can see how closely related it is indeed to this second part of the duodenum, since that's where it grew out of. Now, that's the normal development of the pancreas. There is an abnormality that we should be aware of, and that's an abnormality that's called annular pancreas, in which some of the pancreas forms a ring, annulus means ring, forms a ring of pancreatic tissue surrounding the duodenum. And what causes that is an abnormality in the rotation of the ventral pancreas to get to the dorsal side. We said that normally it rotates from the ventral side to the dorsal side by going around the right side of the duodenum. Sometimes it makes an error in that rotation, and instead of just going around the dorsal side, it splits into two parts. One goes around the left side, one goes around the right side, and then they meet posteriorly. So all of it ends up where it should end up, but because it has gone around both sides of the duodenum, it ends up completely surrounding the duodenum, and that creates this ring of pancreas called the annular pancreas. So annular pancreas is a developmental defect resulting from an error in the rotation of the ventral pancreas to get to the dorsal side, in which it rotates around both sides of the duodenum instead of only the embryonic right side, which in the adult is the posterior side. Clinically, the manifestation of annular pancreas may be nothing or may be something. In terms of the pancreas itself, in terms of the pancreatic acinar cells and the pancreatic islet cells, they don't really care where they are. They just secrete enzymes and secrete hormones, and they go about their business regardless of where they're located. But because this annular pancreas is surrounding the duodenum, it may cause a constriction of the duodenum. So the symptoms associated with annular pancreas, if there are symptoms, are going to be obstructive symptoms, duodenal obstructive symptoms, in which the second part of the duodenum is obstructed, resulting in difficulty in the baby emptying the stomach after a feeding because of the constriction in the duodenum. So symptoms reminiscent of duodenal atresia or duodenal stenosis, in which case the stenosis is being caused by an external compression of the duodenum by the annular pancreas. But if there is no compression of the gut tube, then there are no symptoms because the pancreas just goes about doing its business no matter where those cells are located. So that takes care of the normal development and the abnormal development of the pancreas. So now we'll turn our attention to the development of another organ and look at a cross-section again. And this cross-section, although it looks very similar to the one we were just looking at, is actually slightly more cranial in the abdomen, so that we're looking at a somewhat higher level of the gut tube here. Specifically, what we're looking at here is the stomach. So we have the gut tube, or the stomach, and we have the ventral and dorsal mesentery of that stomach. Frequently, you'll see mesenteries take on names that are specific to the organs they attach to. So the mesentery of the stomach may be called the mesogastrium, mesentery of the stomach, mesogastrium. So we can call this the dorsal mesogastrium. And we see that something is happening here in the dorsal mesogastrium. Something is starting to develop right there. And what that is starting to develop is the spleen. Now, the way that got there is a little bit different, or is actually quite different from what we've seen up until now. Prior to this, when we were looking at the development of the liver and the pancreas, structures ended up in the mesentery by evaginating from the gut tube and ended up inside the mesentery. That did not happen here. This is not an evagination of the gut tube. You see, it's not connected with the gut tube at all. Rather, what is happening is that cells of the mesentery itself, cells of the dorsal mesentery, break away from the mesentery and aggregate between the two layers of the mesentery. So rather than these being endodermal cells, which was the case for the liver and the gallbladder and the pancreas, endodermal because they evaginated from the gut tube, these cells that are developing into the spleen are in fact mesodermal cells because, of course, the mesentery is mesoderm. So that's how we start to develop a spleen, from dorsal mesogastrium cells that break away from the mesogastrium and aggregate together to start to form this organ. Now, as the spleen, this developing spleen, continues to grow, continues to develop, obviously it gets larger. And because it's getting larger, the two layers of the dorsal mesentery between which it is living, those two layers have to spread apart to make room for it. So when we look at our next slide, we see that indeed the spleen has gotten bigger and the dorsal mesentery surrounding the spleen has spread apart to make room for it. So again, looking at the diagram, remembering that the spaces between these lines don't really exist, if we ask the question, is the spleen completely surrounded by peritoneum? The answer would be yes, which means that the spleen is a peritoneal organ, which means that the peritoneum surrounding the spleen has to be called visceral peritoneum of the spleen. So that line that a moment ago we were calling dorsal mesentery of the stomach, it's the same line, but we're now changing its name to visceral peritoneum of the spleen because that's what the rules of nomenclature require that we do. So not only is the spleen derived from dorsal mesentery of the stomach, the peritoneum, visceral peritoneum of the spleen is also derived from visceral peritoneum, from dorsal mesentery of the stomach. Well, now that we have renamed a portion of this dorsal mesentery into visceral peritoneum of the spleen, that leaves us with two other portions of the dorsal mesentery, and we're going to give each of them a name in the adult. This part that is between the spleen and the stomach, appropriately, is going to be called the gastrosplenic ligament, between the spleen and the stomach. And then this part between the spleen and the parietal peritoneum, or between the spleen and the body wall, is going to be called the splenorenal ligament. Now, that name doesn't seem to make much sense on this diagram because the kidney is over here, and one would ask, why should we call that splenorenal ligament? That doesn't seem to have anything to do with the kidney. But indeed, when we wait a while and get to the adult, we'll see that that mesentery will be related to the kidney because some things will move around. And so in the adult, the name makes sense. So let's just call it that starting right now, even though it does not yet make sense, but it will in a while. We know that the spleen needs to have a blood supply. And we know that the source of that blood supply must be coming from the aorta. We know the aorta is over here, so let's put the aorta there. And we'll have an artery going to the spleen, and obviously the way to get from there to there is by going through the splenorenal ligament, and that artery properly is going to be called the splenic artery. So this tells us that we should anticipate that in the adult, the splenic artery should get to the spleen by passing through the splenorenal ligament. And that indeed is the case, and that's a very important anatomical relationship, because surgically, if you need to find the splenic artery in order to stop the blood flow to the spleen, let's say in the case of a rupture of the spleen, it's easy to find the splenic artery even if you can't see much because of the blood in the peritoneal cavity, because if you can just feel for the splenorenal ligament and squeeze the ligament, you'll know that the splenic artery will be within that ligament, and so by squeezing the splenorenal ligament, you'll be compressing the splenic artery and cutting off blood flow to the spleen. And this diagram now shows why, based on embryology, the splenic artery could not be any place other than in the splenorenal ligament, and indeed that's where it is.